Hi, this is Dane Mitchell reporting from Group 4 for our International Health Project. And the problem, real quick, that we wanted to identify was maternal health in indigenous Bolivia. During our research, we discovered that not only is Bolivia one of the poorest countries in South America as far as GDP per capita, but as far as indigenous populations and urban populations, indigenous populations continue to be very, very underserved. And because of this, maternal health has suffered greatly as far as infant mortality and maternal mortality. So this is a problem that we wanted to address that we think is very, very urgent and pressing. And we thought of several ideas on how to do this, and I'll talk about one aspect of what we want to do, and that is to establish small preventative healthcare clinics so that we can outreach to these indigenous populations. During our research, we also discovered that there are many indigenous areas that are very difficult to reach as far as bringing healthcare to them or them coming to us, and because of that, they often don't use the healthcare system that's available. Bolivia's political situation is a little bit interesting in that respect because they have a system of socialized medicine, so they have a guaranteed right to all citizens to take advantage of the healthcare system and use it. But in these populations, they don't have adequate hospitals. They don't have any way for those people to be transported to urban areas to receive healthcare. And that's why we decided to bring healthcare to them instead. So with these small preventative healthcare clinics, people would be able to go and receive high quality healthcare for conditions such as the flu, or if they needed stitches or something simple like that. They could go and receive healthcare for free under a socialized system as it is already established. In addition, as far as it pertains to maternal health, these clinics are going to be a source of information and education for people and health practices. So something that Savannah is going to talk a little bit about as well is, we want to use these clinics as a way to bridge the gap between healthcare and these indigenous populations that aren't used to having healthcare. So not only will they be able to go and receive high quality healthcare, but also be educated on certain preventative practices and maternal health practices that will hopefully decrease the infant mortality and the maternal mortality. In these healthcare clinics, they will be staffed by a doctor, 2 physician assistants or nurse practitioners, and then 4 nurses. And they will be staffed full-time. One of the biggest challenges in using this and having these full-time is how are we going to incentivize doctors and other professionals to work there? Well, here in the United States, we have a program where if you graduate from PA school or medical school and you have a lot of debt, you have the option to work in an underserved area for a period of 3 to 5 years in exchange for payment for your tuition, basically. So that is kind of the idea that we thought of. A lot of this is going to involve working with the government and creating these programs and legislation that allows this, but having the option for a person who's recently graduated from med school or PA school to work in these underserved areas in these clinics for a period of 3 to 5 years in exchange for payment for their tuition. And part of the reason that we think this is so important is because a majority of the population, 60% of the population of Bolivia, lives in these indigenous areas. So 60% of the population is not receiving nearly enough adequate health care to fit their needs. We're hoping that these healthcare clinics will not only bridge the gap between the urban areas and the underserved areas, but we're hoping to eventually create a culture in which the underserved areas right now will be just as good as served as the urban populations. That's our long-term goal, is kind of to bridge the gap in the disparity between the urban and the indigenous populations. That way, indigenous people can have just as good of access to healthcare as urban populations. As far as accessibility, that's our main problem. But we are hoping to, again, work with the government to help create roads that are paved, that function well, to get healthcare professionals out to these areas, and then to have people be able to access them easily. We're hoping that these clinics will serve approximately 5,000 people each, and that is our one of the parts of our ideas on how to address this problem. Thank you.
Hi, my name is Chad Bowman, and as Dane talked about, we're talking about the maternal health in indigenous populations in Bolivia. And one of the things that really stuck out to me is that it's not the lack of opportunity for healthcare that is causing problems, but it's the lack of access to healthcare because of the ruggedness of the country in Bolivia. It's hard for people to travel to different areas. And like Dane talked about, we've talked about setting up clinics with doctors and PAs and nurse practitioners. But I think that one of the things that could be highly effective is for these doctors and nurses and PAs to train midwives that have the ability to travel to the populations, that maybe even some of the indigenous people, so that they know the languages, because there are multiple languages, so that they could communicate clearly and educate and do checks on people who don't have the ability to be able to travel to these clinics. I think that outreach is important because these people, many of these indigenous people, don't have access to vehicles or to the equipment that they would need to be able to travel, so that much of their travel is done on foot. So if we could find a way to educate more people and give them the opportunity to be able to help, I think that the best way to do that would be through a midwife program. Personally, my two youngest children were born at home using a midwife, and it was a great experience, and she was very knowledgeable, and she was while she was giving my wife the care that she needed, she was also training a midwife. And so there were two there. There was a midwife that was trained, and there was a trainee, and she would show her why she was doing what she was doing, talk about it, let her do the checks, talk about what she saw, why it was good, why it was bad. So that training could be done as a peer training and in a less formal setting than going to a medical school or a nursing school or a PA school. So I think to build the numbers of people that we would need to be able to reach a greater number of the population, that a midwife program would be very helpful, especially with peer training.
Hi, my name is Savannah Boyd. As Dane and Chad were talking about, we're serving the women and children in indigenous Bolivia. As Dane was saying that we wanted to bring in midwives by peer education, I found it very important and like a good idea to bring in formal education. In this instance, we would once a month go into the community of the indigenous people, into their village. We are going to ask them to gather themselves in a common place, and that they bring their children too, especially their children right at the age of puberty. Some of the classes that we would like to hold are sexual health, sexual protection, reproduction, sex trafficking, rape, reproductive readiness, menstruation, home birth sanitation, reproductive sanitation, post-birth sanitation, nutrition in pregnancy and while they're lactating, infant nutrition, general nutrition, and we'd like to educate them about the clinic. Some of the classes, briefly, that I believe are thoroughly important will be sexual health and protection and menstruation. A lot of the times, young girls and even the women in the villages don't understand why they menstruate, and I'd like to teach them about the purpose of menstruation and when it will come, when it will go, and where it comes from. Another important one is the clinic. We want to be able to set up trust between the villagers and the doctors, the nurses, the PAs, and the midwives that we bring in. Thank you.
One of our goals is to build trust between patients and medical staff. For example, on our research, we found that many Indigenous people prefer to give birth at home because they feel that their rituals and traditions are being violated in hospital settings. For a Quechua woman, giving birth is done in a dark, quiet room while she paces back and forth in layers of clothing. In the meantime, she is offered hot foods and drinks. They believe that this helps the blood to flow when it needs to. When the mother-to-be feels it's time to give birth, she squats or kneels. She is then tended to by her husband, mother, and mother-in-law. On the other hand, the Western way is completely different, as the baby is born to the world under bright lights, latex-covered hands, and strangers wearing medical masks. The mother-to-be is laying on a medical bed with only a hospital gown to wear, and instead of hot infusions of different plants, she is offered only cool drinks. Although doctors have the say in when to make critical medical interventions, if the mother or baby are in danger, they have the say in when to push. And when the baby is finally delivered and the umbilical cord is cut, it's cut with metal scissors instead of the traditional ceramic scissors used by the Quechua. And in their culture, Indigenous women believe that when this is done, when they use metal scissors, that the child is destined to be wasteful and ungrateful. And so, as our medical staff learns to understand the Quechua traditions and lets the patients have more say in the birthing process, then the number of Indigenous patients will rise while the maternal mortality will fall.